family family planning for the PCP. Specifically on this talk, we'll be talking about infertility evaluation and intervention. Let's see. This, I have no financial relationships to disclose. So our objectives today will kind of set the stage. We'll have the stage itself, which is the meat of the presentation, and then kind of thinking about beyond the stage here. So for setting the stage, we'll talk about the framework to think about infertility evaluation and management, some language that we'll be using today, definitions, the epidemiology, including medical disparities and how this addresses directly the AHEC core topics. And then on the stage, we'll talk about the workup and intervention for infertility and some management options that the PCP does have. And then we'll talk beyond the stage, thinking about the role of the interprofessional team and advocacy avenues. Notably, out of today's scope of the conversation is regarding LGBT plus pregnancy and fertility, as well as beyond the scope will be impaired fecundity or recurrent pregnancy loss management, as that's a different algorithm and would be too much to cover in one talk. So setting the stage, the framework that we'll be using for today's talk is the reproductive justice framework. This is a lens for reproductive healthcare autonomy, initially coined by Black women in 1994, really to ensure that marginalized communities were included in healthcare reform, specifically for reproductive health rights. This combines reproductive healthcare rights as well as social justice. And the definition that I think is easy to remember and really encapsulates this well is the right to become pregnant, the right not to be pregnant, and the right to parent children in safe communities. And so today, specifically within this definition, we're specifically talking about the right to become pregnant in the framework of infertility. But none of these can exist without all of each other in having reproductive justice because it's so integrated to be able to not be pregnant, which includes both contraception as well as abortion care, which may be related to becoming pregnant, depending on some circumstances. This framework for infertility is supported by the American Society for Reproductive Medicine, as well as ACOG, the American College of Obstetrics and Gynecology, and when thinking about infertility management. These things aren't standalone tenets, but really are integrated. Just a quick note on language. When talking about the female partner or the female in this, we're talking about the person with a uterus and ovaries, noting that not everybody who has a uterus and ovaries necessarily identifies as female, but today, because of the literature, we'll be using that terminology today. And similarly for male, it refers to somebody that has testes as their reproductive organs. To define infertility, we'll be using the American Society for Reproductive Medicine, which is kind of a global leader in reproductive healthcare and infertility management, with infertility being the inability to achieve a successful pregnancy. This does not necessarily mean a pregnancy that's carried to term, but again, a successful pregnancy after regular unprotected intercourse after 12 months when the female partner is less than 35 years old, or after 6 months when the female partner is over 35 years old. It's important when thinking about and getting into your history, thinking about primary infertility, which means no prior successful pregnancies, as well as secondary infertility, meaning a prior successful pregnancy. Both primary infertility and secondary infertility can be used to describe either the male or female partner. So who does this affect? This affects worldwide 17.5% of people ages 15 to 49 years old. Although we can have a very separate conversation regarding infertility in minors as a different conversation, thinking about the rights of minors. This is the age range that the majority of the research has been done on. And this can be from a female factor infertility, male factor infertility, or unexplained infertility when the workup for both male and female partners are normal. This comes out to just over 1 in 6 people worldwide, and it's really consistent between different types of country income levels. Both low, middle, and high income countries see similar prevalence rates. Overall prevalence, thinking about what prevalence means as a statistical term, the there's an increasing prevalence globally, meaning more people at one time are affected. And this is somewhat related to societal norms and cultural norms in deciding when people are partnering and or deciding to parent, tending to marriage and childbearing tending to have a later planned time in life in current societal norms. Why should we care about this as primary care physicians? Well, as noted on the prior slide, this affects quite a bit of people and often goes unrecognized by folks. This is important to some of our patients, and for different people have different reasons why it's important to them to grow families or to have children and potentially biological children. And our role is to support our patients and keep them healthy throughout the life course, and a significant time of importance in someone's life course is typically around parenting if they decide to do so. And then there's also health disparities that we as primary care physicians can really fill the gap in. There are well-documented disparities in access to infertility service. There's an ACOG committee statement from January of this year, as well as a American Society of Reproductive Medicine Ethics Committee opinion from 2023 that notes that significant geographic differences in infertility clinics, as these are located primarily in urban areas. So those that have a more urban setting have more access to these infertility clinics because maybe people don't feel comfortable navigating diagnosis and or treatment. There's also a geography in terms of environmental exposures. There was a study specifically about infertility among people that live close to major roadways in China, like big highway expressways, and folks that lived closer to these, which often correlates with lower SES status, had increased rates of infertility, likely due to the exposures from the environment of increased exhaust. There's also concerns regarding environmental exposures in regards to endocrine metabolite interference. Those are not as well documented, but those raise a lot of concerns as well. Again, environmental exposures often disproportionately affect those with a lower SES class based on where the pollution is happening. Minoritized groups, whether it's by race, ethnicity, religion, disability, or even marital status, meaning unpartnered or unmarried people, have differences in receiving diagnosis and care. Often can be something where they're not asked if they're experiencing infertility or trying to become pregnant. We put environmental exposures on here twice. Perfect. It's important to think about. And then financially, there's a lack of inclusion in insurance coverage. It can cost up to, when thinking about the highest level of assisted reproductive technologies with in vitro fertilization or IVF, this can cause upwards of $19,000 for one cycle. And because of these financial implications, this can actually lead to increased neonatal and maternal or birthing parent mortality. There's been studies that show that mandated coverage leads to less of this mortality and morbidity, and that's because of the less pressure to transfer multiple embryos at a time, and thus leading to decreased rates of high order multiple births like triplets or higher. There are 9 states currently that have mandated inclusion in insurance coverage, where these are for private insurance coverages. State-based or federal-based like Medicaid and Medicare do tend to not cover fertility services. And specifically in the ASRM Ethics Committee opinion, they do call out that primary care physicians should be sensitized to the fertility needs of their patients, regardless of practice setting or patient characteristics, where we can really play an active role in addressing this health disparity. This directly relates to AHEC's core topics of addressing social determinants of health, as well as improving health equity, and also navigating these conversations with cultural competency. Is for some patients of certain backgrounds, their marriage or potentially domestic violence situations could be worsened by inability to carry pregnancies. Now we'll transition to this stage, which is the role of the PCP, the starring role here. So before an infertility diagnosis, there are actually interventions that we can do to open the door for further discussions and maybe earlier identification of infertility, or at least opening the door that this is something that a primary care physician can discuss. The One Key Question initiative, which is supported by ACOG, is, would you or your partner like to become pregnant in the next year? If the answer is no, this opens the door for a conversation to discuss contraception and protection from pregnancy. But if the answer is yes, or the patient is indifferent, regardless of the patient being male or female, this does open the door for future conversations about infertility. You can ensure optimal health at this time by managing chronic conditions, encouraging cessation of tobacco use, as this is associated in both in both male and female partners for decreased fertility, with specifically in males with changes in semen analysis and appropriate sperm counts. Limited alcohol use. There's not a great correlation in terms of fertility impact unless there's heavy chronic alcohol dependence in the male partner, can impact spermatozoa production and motility. However, limited alcohol use does not seem to affect, in multiple studies that are contradicting, does not seem to, in some studies it shows increased fertility, in other studies it shows decrease. So it's pretty contradictory in the evidence, but thinking going forward of, if someone were to become pregnant, alcohol use, there's no safe limit of alcohol use in a pregnancy. This is an excellent time to ensure immunizations are updated, specifically in the female partner or the partner that will be carrying the pregnancy, with varicella, rubella, hepatitis B, and hepatitis, as well as screening for hepatitis C. There's no immunization for that at this time. And this is to help protect against possible torch infections or teratogenic infections. You want to review their prescription history to ensure that the person that's carrying the pregnancy is not on teratogenic medications, and make appropriate changes if needed. And it's an excellent time to start a prenatal vitamin for folic acid supplementation in determining or in helping to protect against neural tube defects. The history is going to be the major part of the workup here, and it's ideal to have both partners present for this, because it's important to identify both male and female factor infertility to ensure that there's not excessive workup on one partner, and at times the workup can be more invasive. Starting all visits with a urine pregnancy test is going to be the best form of practice. Although this may be distressing to the patient, it's also important because your visit's going to change significantly that day if that pregnancy test does happen to be positive. And so to rule that out initially is going to be able to help set your agenda. When taking the history, this is a very extensive history of both partners, and so recommended to have a full visit dedicated to this, or potentially 2 visit slots, since you'll have 2 patients, technically both the male and female partner ideally. It's important to know if either partner has had a prior child or pregnancies at all. An intercourse history regarding timing of intercourse, and lubricants used. In several studies, there is showed impaired sperm motility in water-based lubricants and even diluted saliva, but no impact from mineral oil or canola oil. So maybe there may be a potential avenue to discuss lubricants that may be impairing fertility, and be an easy transition to rule that out. For the female partner, obtaining a menstrual history about especially regular cycles and other symptoms like severe dysmenorrhea that may indicate fibroids, or as a structural etiology, or endometriosis as a structural etiology, as well as discussing bleeding with clots and heaviness of bleeding. In terms of a GYN history, you want to know about prior sexually transmitted infections and risk for possible prior current infections, as well as pelvic inflammatory disease that can lead to scarring. Also important in a gynecologic history, because we're meeting people antenatally, ideal to have updated cervical cancer screening. In the male partner, it's important to discuss a thorough history regarding erections and ejaculatory history to identify erectile dysfunction or premature ejaculation where semen is not being deposited appropriately in the vagina. Discussion of injuries or illnesses, or potentially symptoms that they feel externally, such as a varicocele. It's also important to discuss exogenous steroid use or exogenous testosterone use, as this impacts the hypothalamic pituitary gonadal axis, which we'll have a little throwback to med school review in a moment about. For everybody, important to discuss past medical history and past surgical history, specifically in female partners, past surgeries in the abdomen that could lead to adhesive disease, regardless of if it was a specific pelvic surgery. And in the male partner, specifically discussing also prior surgical histories, mostly in the lower back or in the pelvis that could lead to erectile issues, as well as prior surgeries directly to the testes or scrotum. In past medical history, this kind of ties back with the prior slide regarding medications as well and substance use, and ensuring that there aren't lifestyle factors or risks going forward that could be impairing an appropriate pregnancy or be teratogenic to a possible pregnancy. Part 2 of the workup or part 2 of the history taking involves a physical exam of both partners. This includes vital signs, assessing BMI, specifically on female partners, assessing for hirsutism or excessive hair growth or excessive signs of testosterone. Acanthosis nigricans, that could be a marker of insulin resistance, a thyroid evaluation determined of goiter or potentially atrophic thyroid, or possibly also a nodule that needs further evaluation. It's recommended to at least screen for breast changes, including a prominent mass or lump, as well as galactorrhea in both partners. And sometimes a genitourinary examination is needed if clinically indicated. Oftentimes for the female partner with the uterus and ovaries, a GU exam isn't going to give you anything more than what your imaging will, which we'll talk about in a second. But for a male partner, if there's an asymmetry, such as a lump, that could be concerning for a hernia or a varicocele, it would be important to do a GU exam on this partner. At other times, it's needed for evaluation of testicular atrophy. And then the first kind of intervention that we can do for patients is, even if your management of infertility stops here and you get a great history and you set them up with somebody for the next steps, at least things are started. Oftentimes, fertility specialists are going to want to know specifically about cycle tracking. And so recommending cycle tracking with either the old-fashioned paper calendar method, or on any of the phone apps that work for the patient would be recommended. Another thing to evaluate is for ovulation, using ovulation prediction strips. We're often recommending patients in our clinic use these Pregnate packets because it's typically around $15 to $20 for around 50 of them. These are urinary LH surge trackers. Excuse me, that can help predict ovulation. Though it's important to know that ovulation isn't consistent, even in people with regular cycles, it can vary. So potentially using the LH urinary prediction strips can be helpful. Additionally, even when the LH surge is detected on urinary strips, it may be within plus or minus 2 days of ovulation, is what the data shows on it per the ASRM recommendations. However, using cycle tracking and ovulation prediction strips does improve outcomes in terms of achieving pregnancy. So even with these variables of inconsistent ovulation, even in someone with regular cycles, it's still recommended to assist with timing of intercourse. This is our brief interlude for the hypogonadal or hypothalamic pituitary gonadal axis. As a brief reminder, the hypothalamus releases gonadotropin-releasing hormone, which acts on the anterior pituitary gland that releases luteinizing hormone and follicular-stimulating hormones. These hormones act on different cells within the testes, like the Leydig cells and Sertoli cells, which then produces testosterone and induces spermatogenesis. In the ovaries, LH and FSH work on the theca cells and granulosa cells to then produce estradiol and progesterone to stimulate ovulation. The workup,
regarding testing of the female partner often involves labs, which includes thyroid testing, prolactin testing, as this inhibits gonadotropin releasing hormone and thus halts the entire HPG axis, as we saw in the last slide. LH levels and FSH levels can be helpful in a diagnosis potentially of PCOS, which is the leading cause of anovulation, which we'll talk about later. It can also be helpful in determining it specifically in the context of FSH and estradiol on the next page if somebody is appropriately progressing through their cycle. Progesterone can be used not typically on the initial workup, but later to confirm ovulation. Anti-Müllerian hormone is something that can be measured at any time in the cycle. It's not dependent, it's often steady, and this is representative of the size of the follicle pool as it relates to the antral follicles present. You can consider a 21 hydroxylase level to evaluate for a non-classical congenital adrenal hyperplasia if somebody has signs of significant elevated testosterone, like significant hirsutism and severe acne, potentially a deepening voice or other concerning signs. And STI testing is always recommended specifically with gonorrhea, chlamydia, and trichomonas, as these can cause inflammatory changes of the cervix, and the acute cervicitis may change cervical mucus consistency that impairs sperm migration. The initial step in imaging in the female partner is a transvaginal ultrasound. This can provide information regarding fibroids. We're most concerned about submucosal fibroids that can impact implantation and may need to be surgically removed to help increase chances of implantation. Endometrial polyps are another structural issue that may interfere with implantation and can be removed. Adenomyosis is a bit tougher as this is a more globular change to the uterus with the migration of the endometrium into the myometrium. This can lead to, again, difficulties with implantation, and this is unfortunately not surgically correctable, so may need more specialist intervention. Transvaginal ultrasound can also be timed at certain times to get an antral follicle count, which can be used as a marker of the representation of the follicle pool rather than an anti-Müllerian hormone. But this does have to be timed at a certain time. There's also advanced imaging for structural potentially obstructions and a closer look at structure of the myometrium and endometrium. And these include hysterosalpingogram, which you can see an image on the bottom right here. This is primarily where contrast is injected into the uterus, and evaluation is to see if contrast passes through the fallopian tubes and free flows into the abdomen. This image here shows a normal hysterosalpingogram with open fallopian tubes bilaterally. A sonohystogram is similar, but it's typically with agitated saline. This actually has a higher sensitivity for picking up septums and uterine didelphys or bicornuate uterus anomalies, which may be more helpful. Ultimately deciding which to pursue, at times the sonohys can also determine tubal patency because of the agitated saline, the bubbles can be monitored passing through into the abdomen. This is really going to depend on the resources and the user training in your imaging personnel at the location that you're using. And then at times a pelvic MRI is warranted to evaluate for like adhesive disease. Transvaginal ultrasound can give you some softer findings of endometriosis that a pelvic exam could also give you regarding like inability of mobility of the adnexa, immobile adnexa, or possibly imaging an endometrioma on the ovaries. This slide has a summary of the important values when we're thinking about these labs and what that can indicate. Specifically, I want to point out that there's an FSH level over 10 and an estrogen level checked concurrently on cycles day 2 through 5. On any of those days does indicate adequate ovarian stimulation when you're thinking about ovarian stimulation methods. We touched base about the LH-FSH ratio, and if this is above 2, this can be indicative of PCOS. A low estradiol level at any time in the cycle is indicative of menopause, and then a progesterone level above 3, approximately 1 week prior to somebody with regular menses, or on cycle day 21, if somebody that doesn't have regular menses, will be indicative of ovulation. And would be the confirmatory test when you think about using LH, urinary LH search ovulation prediction strips. You can confirm this with a lab value if it's something that your patient desires. And then an anti-Müllerian hormone level at any time in the cycle less than 1 nanogram per milliliter is really indicative of decreased ovarian reserve. However, even if this is noted, this should not be a reason to not refer somebody or not work up infertility. This is primarily associated more with oocyte retrievals, with decreased oocytes retrieved on oocyte retrieval when doing more advanced artificial reproductive technologies. However, you can still pursue ovulation stimulation in these folks, but it's helpful for counseling on expectations. When thinking about testing of the male partner, your labs are going to focus on risk factor modification, evaluating for coronary artery disease or peripheral artery disease, as well as diabetes, can impact erection quality and thus may be an impairment for patients. A semen analysis should be completed twice, 2 to 4 weeks apart, because it's common to have an abnormal one. So having one abnormal semen analysis should not be interpreted alone in the context. And clinically indicated, we'll go to the next slide, that has a nice algorithm from the American Urological Association. There may need to be a testosterone level and an FSH level checked, but that's going to be after you receive and evaluate the semen analysis. The WHO has reference limits for the lower level of normal in semen analysis listed here. This algorithm is really nice and easy to follow and helps you determine if the male partner needs further evaluation. Oftentimes, if the semen analysis is normal, then you really just shift your focus to the female partner. But notably, both from the AUA and the ASRM, both male and female partners should be evaluated in parallel. And that's why I think taking that history taking together of both patients, if possible, really helps set the stage for this kind of evaluation of being, this is a partner problem. Both partners are involved here and both partners need evaluation. Otherwise can lead to unnecessary testing of one partner or the other. As you can see, once you get pretty low into this algorithm, genetic testing may be in order, including karyotyping and Y chromosome microdeletions to evaluate for possible Klinefelter syndrome, or Y chromosome microdeletions that can lead to impairments in spermatozoa production. Things that are no longer recommended and have previously been used are luteal phase endometrial biopsies to evaluate for the secretory endometrial development. This is an unnecessary invasive test for females and is not recommended at all. There has also previously been discussion regarding evaluating post-coital cervical mucus testing to evaluate for sperm motility in the cervical mucus. Again, no longer recommended at all because this is very subjective and very difficult for patients to bring the sample to the provider or the lab. And then no longer recommended, though out of the scope of a primary care provider, is laparoscopy for unexplained infertility. This should be reserved for patients with a high suspicion of endometriosis or previously proven endometriosis. The male workup, some of these are highlighted in orange here. Some of these may be indicated at some point per that prior algorithm, which include the karyotype and Y chromosome microdeletion testing. These are no longer recommended as empiric workups, but may be indicated at some point. This additionally includes scrotal ultrasound, that if on exam there is testicular atrophy or potentially palpated absence of the vas deferens, a scrotal ultrasound for confirmation may be necessary. Or if there's a bulge in the scrotum concerning for a varicocele or possible possible hernia scrotal ultrasound may then be warranted. DNA fragmentation of sperm testing is no longer recommended empirically and should really be only done by a very, very specialist male infertility doctor, and even then the recommendation is low. There's also just hard stop, red flag stop signs for immediate referrals, and this includes primary amenorrhea, which the workup should start in the primary care physician's office, but this may require significant fertility management with advanced reproductive technologies and potentially gestational carriers. So even if there's known primary amenorrhea that has been previously worked up and has a diagnosis, working for fertility in these folks should be navigated by a fertility subspecialist. Finding structural disease on your workup should be referred, as this may have options for surgical management and correction. Finding aspermia on a semen analysis, meaning there are no spermatozoa present, is an immediate referral as well, because there may be proximal obstructions or very specific reasons why someone's not making any sperm at all. That should be worked up by a male infertility specialist. That may ultimately require sperm harvesting directly from the testes if there is production that's being obstructed. Prior chemotherapy or radiation therapy that's affected the GU system should be immediately referred, as there's other complications that can occur. And then if idiopathic infertility is found in your workup, this should be referred as well. And this means a completely normal workup on the male partner semen analysis, and a normal workup in imaging, tubal patency, and ovulation in the female partner. Who are you going to refer to? Potentially, this may just be a gynecologic surgeon that is well trained in addressing structural disease, but this also could include the reproductive endocrinology and infertility specialist, or a urologist in the case of males that specializes in infertility. So what can we do as primary care docs? For our male patients, identifying erectile disorders is going to be our primary role here. We want to optimize health, as we mentioned before, ensuring diabetes is under control, and that risk factors for cardiovascular disease are also addressed, which may mean putting a patient on a lipid to decrease progression of atherosclerotic disease. These can affect both nerves and blood flow in the penis and ultimately impair erection. For erectile dysfunction, either psychogenic or organic, organic meaning coming from things such as diabetes, and psychogenic meaning that a patient is able to obtain erections with masturbation, or has morning spontaneous erections, but when with their partner unable to obtain appropriate erection. Phosphodiesterase 5 inhibitors such as sildenafil is appropriate for primary treatment of either of these causes of erectile dysfunction. In patients experiencing premature ejaculation, topical desensitizers like topical lidocaine are available over the counter, but SSRIs are also effective here. There may need to be a referral to a sexual health therapist to address this from a psychosocial perspective as well. And luckily, in the day and age of online therapy, this may be something accessible to patients even in more remote areas, more rural areas. Decreased libido, which is you first want to identify that this is not a hypoandrogenism effect, but would need to do a thorough evaluation and history taking. There's guidelines on the AUA to determine low androgen state. Decreased libido is also common in partners trying for fertility, as it can be very strenuous to and very stressful to be trying to time intercourse all the time, especially when people have been trying for some time. So it's also important to identify if that's maybe more of a psychosocial decreased libido. Notably, exogenous testosterone, if you do identify hypoandrogenism, should be avoided at all costs. This patient, if desiring biologic pregnancy should be seen by a fertility specialist for gonadotropin releasing hormone, or LHFSH. Typically injections, but medications to stimulate natural testosterone production and ultimately spermatogenesis. Exogenous testosterone actually shuts down the testes and thus would inhibit spermatogenesis further. As a cost-friendly option, just on GoodRx, I put an example here. Sildenafil is quite cheap. This is for the 25 milligram tablet, but ultimately this is a cost-friendly way for these types of disorders in our male patients that may benefit from some assistance with overall limited financial impact. Primary care intervention for anovulatory cycles. This is an excellent place where primary care physicians can intervene. Anovulatory cycles are 15% of all infertility and make up around 40% of female factor infertility specifically, per the ASRM. PCOS is the most common cause, polycystic ovarian syndrome, which should be diagnosed and significantly discussed. There's a lot to uncover here in terms of long-term metabolic consequences for patients. Other causes of anovulation can occur as well, and this is not necessarily due to PCOS, but also just due to elevated BMI and obesity, perimenopausal, significant weight gain or weight loss, and then strenuous or excessive exercise, also in very thin patients or underweight patients. What we can do here is ovulation induction with letrozole specifically. Letrozole is an aromatase inhibitor. I'd say in the primary care setting, we often avoid using clomiphene due to the higher risk of multiples with multiple follicle development. However, that's also an option for patients. If patients aren't having menstrual cycles that they can time with ovulation induction, and on the next slide, we'll discuss how to time that. Then you can use a medroxyprogesterone or a Provera challenge to induce a withdrawal bleed and then start your cycle on day 1 of that bleed. And then using anovulatory cycles, while we're using ovulation induction for this, it's important to confirm ovulation. And here you can again recommend that patients, for a cost-friendly option, use ovulation prediction strips, or potentially you could check that luteal progesterone level on around cycle day 21. How do patients use letrozole? I have made myself a dot phrase for my patients, both in English and Spanish for this, and I've also used that myself to help remind me how to prescribe this. So it's really important to have patients track their cycles or start tracking their cycle when you're going to start using letrozole. The first day of bleeding is cycle day 1, and this can be the first day of bleeding when using a medroxyprogesterone challenge. Starting with letrozole 2.5, this is an oral tablet that should be taken on days 3 through 7. And in subsequent cycles, you can increase this dose by 2.5. If you're not achieving ovulation on the 7.5 maximum dose, then that would be an indication for referral as well. Ovulation prediction strips, you're going to have your patients start that on cycle day 10 until this is positive, and you would anticipate that this will be positive around cycle day 12 to 14, and thus recommend intercourse on days 12, 14, and 21. You can consider that confirmation of ovulation on cycle day 21 with the progesterone serum level, and then ultimately a pregnancy test on cycle day 29. This is a calendar that I've made just to help visualize how to use this. The numbers here are not dates, they're cycle days. So the first day of bleeding, indicated by the blood drop, would be cycle day 1. And you can see the large L to indicate days that letrozole should be taken. On cycle day 10 here, you see that ovulation prediction strip should be used until positive, and the heart is there to indicate intercourse. On day 21, you have that serum progesterone and on day 29, or what would be cycle day 1 of a 28-day cycle shown here, would be the pregnancy test. Now thinking about how this goes beyond the stage or beyond an individual patient. The interdisciplinary team is really important here. Psychology or mental health support is important, as at least 30 to 40% of female partners undergoing infertility have depression, anxiety, shame, grief, feelings of a lack of femininity, or potentially a lack of
purpose, or possibly any sort of feelings here. This is also under addressed in male partners undergoing infertility treatment, regardless of who the regardless of if the infertility is identified to be male, female, or both. Social workers and community health workers are important for resources in this time frame, especially if a pregnancy is obtained, including connecting folks with WIC and SNAP, nurse family partnership, in some cases, parents as teachers, or the infant toddler program at times. And there's a big role for advocacy here. My first role for advocacy today is doing this presentation and knowing your role and your scope, and that this is within our scope as family medicine providers. We can expand access to our patients, and that may even be by having diagnosis and having that door open, potentially discussing how common this is for patients to experience so that they feel less alone, and connecting them with support groups in that way. And ultimately, we should all be advocating for expanded insurance coverage for fertility, as this is the WHO, the AMA, and multiple organizations do have clear statements that infertility is a diagnosis, and it's an appropriate diagnosis, and it should be treated if patients desire that. Some final takeaways. Infertility identification and diagnosis, and some of the treatment is in our scope. ACOG and ASRM have excellent resources. I recommend dedicating at least a full visit to this, and likely multiple recurrent visits. And there are financially conservative options for patients, like ovulation prediction strips, cycle tracking, and ovulation induction with letrozole. And otherwise, it's still our job to identify this and refer as soon as possible if you're not comfortable. This may be somebody within your practice that is more comfortable with this, and this may be more advanced subspecialty care. Again, big support for ASRM and ACOG. Thank you, and I'm happy to take any questions.
Hey, Dr. Buening, Abby, David's here. That was an excellent talk. Really learned a lot. I had a question. You had had a slide about semen analysis, and is that recommended to do twice in everybody, even if the first one is very normal? That's just what I wanted to clarify. That would be a practice changer for me.
If the first one is very normal, AUA says you can stop with a normal one, but other resources do say still getting two is important to verify that that was correct and not essentially like a fluke. Sometimes patients need more if they continue to be contradicting each other. And there's a lot of difficulty also in semen analysis to ensure that it's provided and evaluated in a timely fashion because of the necessity to keep the sample warm and be evaluated within 1 hour. You have to there's a lot of coordination involved. So I think oftentimes my understanding was still doing 2 is recommended, but I hear you, like when we're thinking like helping patients with financial hardship, evaluating this, I think it's pretty comfortable to stop with a normal one.
Cool. That's good to know. I will offer that more than once.
Are there any other questions for Dr. Buening?
I also just really loved your calendar and think that is an awesome patient resource. Thank you for sharing that.
Yes, thank you, Dr. Buening.